Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to explain the leading forms of psychological therapy in a way that is understandable to everyone. Today, I'm honored to welcome Dr. Stephanie Carnes, who is here to discuss the topic of compulsive sexual behavior disorder, which was recently designated as a mental disorder by the World Health Organization in the upcoming ICD-11. Dr. Carnes is the president of the International Institute for Trauma and Addiction Professionals, more commonly called ITAP, a training institute and professional organization for addiction professionals. Dr. Carnes is a senior fellow at Meadows Behavioral Healthcare, where she works with sexually addicted clients and their families. Her father, Dr. Patrick Carnes, is the founder of ITAP and is an internationally recognized expert in the field. He also created the assessment tool and the 30-task model treatment modality, which is used by clinicians all over the world to help their patients recover from sexual addiction. Dr. Carnes' credentials include being a certified sex addiction therapist, a clinical sexologist, a licensed marriage and family therapist, and a supervisor specializing in therapy for couples and families struggling with sexual addiction. Dr. Carnes is the clinical architect for Willow House at the Meadows, which is a 45-day inpatient program designed specifically for women who are struggling with love addiction, relationship issues, and intimacy disorders. Dr. Carnes currently co-facilitates Module 2 in the Certified Sex Addiction Therapist Training, as well as the Certified Partner Trauma Therapist Training. She is the author of numerous publications, including her books, Mending a Shattered Heart, A Guide for Partners of Sex Addicts, and Facing Heartbreak, Steps to Recovery for Partners of Sex Addicts. Dr. Carnes, welcome to The Therapy Show.
Thank you for having me, Bridget.
Can you start by telling us a little bit about your personal background and professional development that led you to working in the field of compulsive sexual behavior disorder?
When I initially got into the field of psychology, I was actually in a different arena. You mentioned during the introduction, I have a very famous father, Dr. Patrick Carnes. And so when I got into the field, I actually went into a completely different direction, just kind of wanting to pave my own way initially. And so I was in medical family therapy and worked with spinal cord injuries and brain injuries. And so I was actually on a very different path. And over time, he kind of kept on working on me and was like, come work with me. Let's do this research project. Come to this training. And I just got more and more interested in addiction and sexology. And at one point in my life, I was really ready for a change. And I went to the director of a family therapy program in a treatment center that had a sex addiction unit. So that's where I started. So as a family therapist, obviously had a long-standing interest in working with families and a passion for working with couples and children. And so I found the work very interesting, but also very challenging because, as you can imagine, sex addiction is just devastating for families. And as I was working there, over time, I became the director of the sex addiction unit. And I just found the work tremendously rewarding to see people turn their lives around. As you can imagine, people going inpatient for sex addiction treatment have typically really destroyed their lives as a result of their sexual behaviors, lots of suicidality, lots of major life consequences, lots of very damaged relationships. But I found the work very rewarding to see people turn that around. And I started to really believe in the magic of recovery and started to see a lot of success in the clients. And that was very exciting for me. And then since that point in time, my father and I have been working together for over 20 years now, unbelievably. And I ended up also having in my marriage, which I'm many years divorced now, ended up having some betrayal experiences that led me to have a lot of insight into partner issues. And that really changed my frame of how to work with partners. And I ended up writing a couple of books for partners of sex addicts out of that process. And so I've been now working in the addiction industry for like 20 years. And it's been wonderful. My most recent work has been, as you mentioned in the introduction, developing a women's program for women with sex, love, relationship, addiction. So we now have one of the few residential programs for that in the country. And it's been just really rewarding work. And so that's kind of a history of how I got into the field.
When and how did you realize that a sexual addiction and partner trauma approach to treating compulsive sexual behavior disorder would be an effective therapeutic intervention?
So, given my father's work and having been introduced to the field through him, he was sort of the grandfather of the addiction model, the sex addiction approach to treatment. He actually was in recovery himself and started the first SAA group up in Minneapolis back in 1977. He wrote some of the first books on sex addiction. I was kind of raised up with the addiction model and using addiction lens. And, obviously having worked at treatment centers, and I've also done a lot of outpatient work as well, but that's been a model that I've used for many years. Later on, I also got training as a certified sex therapist and a clinical sexologist, which broadened my perspective on sexual health and sex therapy issues. So I incorporate all of that into my work now. And of course, there's been a lot of changes and controversy in the field around what model is better and what are we going to call it, given that we still don't have a diagnosis in the DSM. Fortunately, the World Health Organization has taken a step forward and finally drawn a line in the sand and given us a diagnosis of compulsive sexual behavior disorder, which goes a long way to help legitimize the work that we do. So there's still a lot of people out there, talking about different approaches to treatment, and we incorporate a lot of those different approaches into our work with clients. In terms of partner work, I initially was brought up using codependency perspective. And then when I went through my own experience and when some of the new research started coming out about betrayal being a relational trauma, that really shifted my lens to starting to look at partners of sex addicts having their experience be relational trauma experience, or what I usually call betrayal trauma. About 10 years ago, my work really shifted over and took on a betrayal trauma format. So I've been mainly using that lens in my work with families since that point. We use a lot of different types of trauma treatment. Obviously, there's very significant levels of trauma in the population that I work with, and many times complex trauma. So we use many different types of trauma treatment approaches, as well as a 12-step approach as an adjunct to therapy. I should mention too, obviously, the work that I do with ITAP, I do a lot of training on the task model, which is Pat's original theoretical formulation on how to work with sex addiction or compulsive sexual behavior disorder. It's 30 tasks, called the 30 task model. And it has specific tasks that help bring the addict through their treatment process. When talking about the patients, he says you have to grab onto the frontal lobes and hold on. The task model is very insight oriented. It's also a bit cognitive behavioral and really coincides with the work they do in their 12-step program in terms of going along with recovery principles, things like honesty and accountability and integrity and those kind of things, and trying to get those values back on board with somebody working a recovery program. It's also a very comprehensive model to treatment. And that's the model that we teach in the CSAT training. We do incorporate other perspectives as well, but by and large, it is based on the task model that Pat created.
How would you briefly explain what compulsive sexual behavior disorder is to the non-professional? I mean, we used to call it sexual addiction, but what is it?
It's basically when an individual has a relationship with sexual acting out that causes them significant consequences and they continue their behavior despite adverse consequences. Oftentimes what we see with compulsive sexual behavior disorder is a medicating component in which they are using the behavior to medicate anxiety or depression or feelings of shame and trauma, those types of things. So they're using it in a compulsive manner. The typical types of things we see is an escalation in the behavior. We see it causing physical health consequences, job loss, financial loss, relationship consequences in all sorts of areas of life. We often see a lot of preoccupation around the behavior. excessive amounts of time spent on the behavior, feelings of withdrawal when they can't access the behavior, a loss of control around the behavior. So those are the kind of symptoms that we see when we're dealing with someone who's a sex addict.
So who is this approach most effective for? Why should people choose a therapeutic intervention that includes sexual addiction and partner trauma treatment?
Well, I would say it's most effective for people that are motivated for recovery. You can think of it very similar to chemical dependency in that, it ranges in terms of people's readiness to change and their awareness of how their behaviors might be impacting their lives. Just like with substance use, you have a lot of people who recreationally use substances and it doesn't really cause them major consequences. It's not really a problem. Well, you have that with sexual behaviors too. So for example, you have a lot of people that recreationally use pornography, for example, and don't have problems in their lives because of it. But then you have the continuum where whatever the behavior is starting to take more and more time. They're starting to have consequences, and it's starting to look more like what you'd see with substance abuse in a substance abuse situation. And so people start to have consequences and start to become aware that it's a problem. Those are the people that are going to benefit most from treatment because they're the most open and the least defended and most ready for treatment. So those are the kinds of people that would probably benefit most. But in terms of the types of behaviors that people engage in, we get just a little bit of everything. I've heard a lot of different kinds of problems over the years, and whether it's problems with porn or strip clubs or prostitutes or multiple affairs, or really doesn't matter what the sexual behavior is. It really is about their relationship to the behavior. So those are the kind of people that we're most effective helping.
What about young people? Are you seeing a younger and younger population?
We are seeing a younger and younger population. If you look at prevalence data, there was a study that came out 5 years ago that looked at prevalence data, and it looked at many different studies from like 10 years ago. It kind of was a synopsis of many different studies, and they kind of averaged the prevalence at about 4.5%. And then just this last year, there was a large study done by a group out of Minnesota, Eli Coleman. They did a study on a nationally representative sample that looked at all different ethnic groups, different socioeconomic statuses, orientations, all of that. And they found problematic behavior in 10% of men and 7% of women, which was much, much higher than anticipated. And if you look at college student samples, they're even higher than that. And so I think the ease of use of today's technology, sex apps, pornography, just the culture that we're living in that's really trending towards more virtual and non-relational sex, we're starting to see a big increase in the amount of addiction. And you actually see that with all addictions. You see that like in areas where you have more meth labs, you have more meth addiction, where you have more casinos, you have more problem gambling, where you have more bars, you have more alcoholism. And now everybody's got a smartphone. And we are seeing a lot more. And we're seeing even problematic behavior in teens and even very young people. So we are seeing it at a younger and younger age, definitely.
What's the average length of treatment for somebody working with a therapist trained in sexual addiction and partner trauma therapy?
Well, that really varies. It depends on obviously how acute their situation is and the kind of problems that they're dealing with. Like, for example, with pornography, you can have somebody get into recovery from pornography and really kind of embrace it and recover pretty quickly. When you have people that have lots of trauma history, acting out that's really damaged their lives, destroyed their families, if you have suicidality, if you have, narcissistic or antisocial features on board with the client, those are the kind of things that can prolong treatment. But typically, we do recommend that addiction recovery is a long-term process. And I would say for the typical sex addict that is acted outside of their relationship, we look at recovery being like a 3 to 5 year process for them. We recommend them being involved in groups, accountability groups, and other forms of outside support in addition to therapy. because without that, it's usually not enough to maintain sobriety.
When you look at your training and how well trained you are in this field, which is a new emerging field in the field of psychology, do you think it's important for somebody who has this issue to be seeing a therapist who is trained in this model? Why is it important for somebody to have this background? I'm intuitively thinking it could really hurt someone, but what do you think?
Absolutely. It's critical to have training if you're going to do this work. And I think a lot of well-meaning therapists will kind of hang their shingle and say that they treat sex addiction, and then they get in over their heads, and there's ethical problems and legal problems. And there's just so many ways that you can get in over your head with this. Like, for example, the training program that we teach is 4 modules. It requires supervision. It has ethics. I mean, there's just so many areas when you're dealing with this that can be problematic. So, for example, just give you a few examples of that. Sometimes when people come in, you have to really do a very comprehensive assessment. So we do very extensive testing instruments that require a lot of training, that are normed on thousands of people so that we can accurately assess the individual, because people aren't always honest when they come in. And sometimes you have offending behavior that gets in the mix. And so you don't really know, am I treating just an addict? Am I treating an offender? It's very easy to get outside of your scope of practice and outside of your scope of competence. There is, sometimes dangerous people whenever you're dealing with people that have sex offending behavior. So you want to have training on when to refer, how to handle those kind of situations, how to handle. Another issue is sexualizing behavior in therapy. Learning how to handle that is very important. How to do another huge issue, how to do effective disclosures with the partner that is the least traumatic as possible. So when doing couples therapy, it's very important for the addict to come clean with the partner about what they've been doing. And that's an extremely traumatic experience for a partner. And there are well-meaning therapists that march into those situations and create huge explosions and do really unethical disclosures and get into situations where there's no safety plan. It's done really irresponsibly. So I highly recommend people that work with this population get extra training. And then there's also all the issues of the sexology and the interface of sex addiction and sexology, like paraphilias, working with paraphilias, and sexual dysfunctions, which is also not that uncommon with this population. So it really is a specialty area.
And what is sexology, just for the non-professional?
Unfortunately, our field, the sexual health field, is kind of split and is sort of split into silos. So you have people that work with sex offenders, you have sex therapists, and then you have sex addiction therapists. And there's sort of like 3 different camps. And it's really unfortunate that it's like that, because there's so much to learn from one another in these camps. That's one of the reasons why I went and got my sexology degree and have done some training in sex offender work. It's really, really important for us to have the broad lens of the whole field. But unfortunately, that's not the way it is. So sexology and sex therapists typically focus on the arena of sexual health, things like sexual dysfunctions, medical issues relating to sexuality, things like menopause or vaginismus or pelvic floor pain, things like that, transgender issues, LGBTQIA issues, also paraphilias. All of those kind of fall into the sex therapy realm. Throughout time, these different camps have not always been trained well in each other's areas. So there's a lot of, for example, there are some sex addiction therapists that aren't well enough trained in sex therapy. There are many sex therapists that know nothing about sex addiction. So it's important that the fields start learning to cross-pollinate and cross-fertilize in terms of information so that we can better treat our clients.
What are the most common obstacles or missteps that prevent therapists and patients alike from seeing the full benefit of sexual addiction and partner trauma therapy?
So that's two really different questions. The missteps for therapists is really different from the missteps for patients. Let's see, I'll tackle the patient one first. One of the biggest missteps I see for addicts in recovery is not getting honest completely and 100%. There's so much sexual shame around their behaviors, and we work really hard to help them reduce their sexual shame, and being in group with other people struggling with the same things really helps with that. But there's so much sexual shame around their behaviors that sometimes they feel like they have to take this piece of information to their grave and they don't put it all out there. That creates so many problems for them later on. Bill W. of AA has a famous phrase is, those that can't recover are those that are constitutionally incapable of being honest. And another famous phrase is, you're only as sick as your secrets. And for whatever reason, it's very hard for addicts to come clean around their behavior, and it creates huge problems. As a matter of fact, just right now, I'm dealing with a couple in couples therapy, and the addict, he lied all throughout treatment, all throughout. He went to inpatient, he went to outpatient, and then was doing intensive outpatient, then he stepped down to outpatient, and then got to the point of doing a disclosure with his partner and had the polygraph, and it turned out that he was lying, and it came up on the polygraph. And that was a really late point in the game for him to come clean around this, and it almost cost him his marriage. I'm the couples therapist, and we're still doing a lot of hard work around that. And so I really encourage addicts in recovery to just rip the Band-Aid off and really surrender to the recovery process and get really invested in surround yourself with people who can really support you in your recovery. Let's see, for therapists, I would say staying in your scope of practice. I would say it's a very common misstep for therapists to kind of get in over their head and treat someone that they're not trained to treat.
That makes sense. Can you share any poignant examples where sexual addiction and partner trauma therapy had a major impact in someone's life? Of course, without giving any identifying information.
I know so many recovering sex addicts and their partners that the thing I always emphasize to my couples is, first of all, recovery is possible, healing is possible, and recovering addicts can make great partners when they're in recovery and really working a program. And they do. And so it's people that are really invested in recovery, their lives are transformed. And it can be an amazing journey. They can end up being so much better off than they ever were before any of this pain started for them. And sometimes when people are early in the process, they can't imagine that they'd ever come out stronger as a couple, but they do. Couples that stay together and work on it, and when both parties are really invested, so often when I have many colleagues and friends in long-term recovery that look back and say, gosh, if this hadn't happened to us, we would have never gotten to this level in our relationship. So recovery is really, it can be really magical and transformational for people in their lives. And I think it's important for therapists to continue to convey that hope and let people know that this really works when they work it, basically.
I'm just looking at the words partner trauma therapy, and I think about the trauma that comes along with betrayal, being told that there was some betrayal involved. But when you think about the word sexual addiction, I wonder, is there a need to treat the sexual addiction as a trauma-based? Is there trauma that maybe leads to sexual addiction?
Oh, yeah, absolutely. That's why trauma treatment is so critical for this population, because it's not uncommon for both parties to have very significant trauma. Trauma is a huge factor in the etiology of sex addiction, and, in the development of the disorder. The majority of our addicts have trauma history. And so it's critical in their healing process. And unfortunately, it's overlooked many times and isn't done as in depth as people need to go. And so I really, in our programs, we use so many methods of trauma treatment because it's the core of healing for a lot of people. So we use, just for example, somatic experiencing. We use EMDR. We use internal family systems. We use psychodrama, we use art therapy, just to name a few of the primary ones we use. And that's for all of our patients because it's fundamental to their healing process. And then from the partner's perspective, if they didn't have trauma before, and many times they do, and they can benefit from their own trauma work, but if they didn't have it before, then they do now, oftentimes after the addict's disclosure. So if you look at some of the research around partners, about 70% have significant PTSD and difficulty functioning in their day-to-day lives after discovery of sex addiction. So it's devastating for them. When we look at partners, this just in general, sex addiction, from a cultural standpoint, we have so far to go in terms of destigmatizing this. We're like where alcoholism was like 40 years ago, where we used to look at it as a moral problem and a lack of willpower and not real. I mean, you still hear people saying sex addiction isn't real out there, which is just ridiculous. And so there's so much misinformation about what it is and what it isn't in the media, and people make a lot of assumptions. So it's still so highly stigmatized. So not only does the family have to have, struggle with all the issues relating to recovery, but they oftentimes feel like they can't tell anybody about it. They have no social support, even though it's hugely traumatic for them. I had a partner say to me recently, I had cancer and this was so much worse than going through cancer treatment, but I have nobody I can talk to. And so betrayed partners are still very stigmatized. If you look at how our culture treats betrayed partners, there's a lot of ignorance and assumptions that's made. Like, just think of how people treated Hillary Clinton and things that were said about her during her whole experience with Bill Clinton. So there's just so much stigma about this for both parties. And we as a culture have to start waking up that this is a real problem, that people can heal from this, and that it's treatable. I think we're making progress in that, but we still have a ways to go.
And I think about if sexual addiction has most likely a trauma base, then I think we can have compassion for people who may have a sexual addiction. I mean, and there's some compassion that we can have and some destigmatization that can occur, don't you think?
Oh, absolutely. Compassion is critical. These clients hate themselves. Any beating up that we could do to them, they've done it 100 times over, 1,000,000 times worse. So, I mean, there's so much shame and feelings of worthlessness and self-hatred. That's why we have, on our unit, we have such high rates of suicidality that we have people that just are on one-to-one suicide watches all the time and have to do a lot of stabilization with these clients. And of course, the antidote to that is compassion. All of these clients have their own story of how this ended up happening and how they got there. And once you start hearing some of these stories, you start to realize, wow, there's a reason and a cause for everything. Even the ones that don't have trauma, sometimes we do see some of our younger porn addicts. Porn is just so highly addictive that we get a lot of young people that got exposed really early to graphic, intense media and became addicted at a very young age and don't have that trauma history like we do with some of our typical sex addict cases. But even in those cases, being exposed to porn when you're 8 years old is traumatic. And thinking about what this child's experience was of having hours of porn on their handheld device throughout their childhood, there's always a compassionate lens that we can put on the experience of these clients.
So who's sexual addiction and partner trauma therapy not appropriate for?
Well, obviously, anybody who's not a sex addict. Sometimes there's important for therapists, there's important differential diagnostic factors to keep in mind. Like, for example, people with paraphilias. So let's say you have someone come in that is cross-dressing and struggling with that, but they don't really meet the criteria for an addiction, meaning their behavior isn't really compulsive, but they're just struggling more with like shame around the fact that this is their arousal template. So someone like that is going to benefit a lot more from traditional sex therapy techniques of trying to help them get comfortable with this arousal template and maybe can they incorporate this into their lives in a healthy way, for example. So that's one example. Another example that's a really important example would be at times there are people that are struggling with unwanted same-sex attraction, and they feel like it's an addiction and they want to seek sex addiction treatment, thinking that they can rid themselves of their unwanted same-sex attraction. And this is one of the things that in my organization, ITAP, is very, very adamant about, is sex addiction therapists do not provide conversion therapy or reparative therapy or tell clients that they can change their sexual orientation. So, that requires really, meeting with the client, meeting them where they're at and having them be realistic about their arousal template and that this is probably not going to go away, and have them reflect on what would it be like for them to question and consider changing their orientation. There are many people that don't want to do that because it's outside their value systems. And of course, we respect that. We always respect the person's desire when it comes to that issue. But to tell them that, for example, sex addiction treatment is going to change their orientation is something we, among our membership of certified sex addiction therapists, all of our therapists sign a form stating that they will not participate in conversion therapy or reparative therapy just because we know it's very damaging to people. So those would be a couple examples. We'd want to really make sure that the person is appropriate for treatment.
You use the term arousal template. Just for the non-professional, what does that mean?
So your arousal template is your erotic map, basically, what it is you are aroused by and what you find attractive. And so that ranges from everything from body shapes to genders to processes to behaviors. So it could be anything from, I like sex outside, I like to use sex toys. So anything that is a turn on for you is part of your arousal template.
What are you most excited about in mental health treatment today?
As you can hear, I'm really passionate about this field. I'm passionate about trying to get this illness legitimized and the word out there that this is a real problem that's treatable. As I mentioned earlier, I'm very passionate about that. And so I try to do some advocacy in that area and a lot of education in that area. I do a lot of conferences and that type of thing. I'm also really passionate about betrayal trauma. I think that's a very important lens for people to look through. I'm passionate about doing the disclosure process right. I've done some research in that area and writing in that area. And I train people, and in the CSAT training, I train all of our candidates how to do disclosures in a safe and effective manner. I'm passionate about couples work. I've got a new book coming out that I'm excited about. It's for couples. It's called Courageous Love, a guide for couples conquering betrayal. So it's written for couples with infidelity, porn, sex addiction, any kind of betrayal in their relationship. And so that'll be coming out over the next few months. So I'm pretty fired up about that right now.
That's very exciting.
Yeah, I'm also excited about children's issues. Obviously, as an adult child of an addict, that's something that's also near and dear to my heart. So I do a lot of speaking on that as well.
If you had a magic wand and could improve one thing about mental health treatment today related to your field, what would that be?
Oh my goodness. Well, first of all, I'd give us a diagnosis. Second of all, I would increase the amount of neuroscience research, genetic research, and outcome research that we have. Those are three areas that we really need to grow as a field. I think that's really important.
So how can my audience learn more about your work, either online or in print?
You can look me up at itap.com. So ITAP is the organization that's where they can learn about the CSAT training. They can also look me up at the Meadows. So Willow House is our program for women, and Gentle Path is our sex addiction unit for men. And those are obviously gender separate units. And I'm super proud of our programs there. Yeah, so those are the easiest places to find me.
Dr. Carnes, on behalf of myself, my listeners, and all of the people that you have helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of compulsive sexual behavior disorder.
Thank you. Thanks for having me, Bridget.
Be sure to check out my website, www.therapyshow.com, which has many resources about mental health and also a page dedicated to Dr. Carnes' work and her dad's work. There you will also find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I can interview and how I can improve the show. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so that you, someone you love, and people around the world can gain more benefit from therapy. There is no need to suffer in silence. Get the help that you need to create the life that you want.